Hello students. Before I begin this last chapter on care of the patients with cancer, I just wanted to go over the concept of DIC, disseminated intravascular coagulation. This is a problem or defect that we see on occasion that arises with our patients when they have underlying condition, which makes them very predisposed to developing DIC. It's a defect. It's often fatal, and what it does is it causes an activation of the intrinsic clotting system by the release of factor 12. Okay, and how this occurs is it's usually triggered by some kind of serious illness, such as like sepsis, maybe trauma, maybe someone has cancer, shock, even abruptio placenta, even toxins or some kind of allergic reaction. The severity of DIC is variable, but it is potentially life-threatening. Okay, mortality exceeds about 80% of patients who develop severe DIC with some kind of ischemic problem from thrombus and even frank hemorrhage. The goal here is to hopefully prevent DIC from occurring. So we want to definitely treat the underlying condition that may have precipitated a person or one of our patients to develop DIC. Okay. And as I said, it occurs as a result of some type of major insult to the body, usually sepsis. Also, it can be a highest incident is postpartum from contamination during a delivery. So what happens is this bacteria builds up a small microemboli all over the body that uses up all of the clotting factors, and then the patient begins to bleed from everywhere. Okay. So the thrombus is obviously in the venous system and the emboli are in the arterial system. So if you go back when we talked about normal hemostasis or normal clotting, these normal hemostatic mechanisms are all altered when someone develops DIC. There's a massive amount of tiny clots that form in the microcirculation. And initially, the coagulation time is normal, but as the platelets and the clotting factors are consumed to form the microthrombi, then coagulation starts to fail, and it goes from microemboli to excessive bleeding, okay, because all the clotting factors and platelets are all used up, all right? It precipitates that condition to occur. Then that excessive clotting triggers the fibrinolytic system to release those fibrin degradation products, which are potent anticoagulation, furthering the bleeding. And the bleeding is then characterized by consumption of platelets and clotting factors. So what happens is you start seeing a decrease in platelets and fibrinogen levels due to the consumption of fibrinogen being used up. So then eventually you'll see a prolonged PT, PTT, and thrombin time and increased fibrin degradation products. So if you would assess the lab value of D-dimer, you would see that increased. Okay. So I think what I'm just trying to say is I think we have to think about why would a patient acquire DIC. And like I said, maybe at this point in Nursing 210 you aren't taking care of patients who are extremely ill. That may occur as a result of problems from maybe an infection that they might become sepsis as we care for them in the on the med-surg floors. But you might see this more in patients who are in critical care units, who are, admitted to those units because of, severe problems like, sepsis or complications from cancer or, a burn unit. You got to think that when they have this very traumatic and major insult to the body, that they have the potential to develop DIC, okay? or when a woman is going to deliver. If proper sterility and aseptic technique is not maintained, then obviously that mother would be at risk for developing a type of sepsis and could possibly be a candidate to acquire a DIC. Okay, but I guess you just have to think of it in that way. And at first, it begins to develop all this microemboli, okay? And then when all those platelet products and fibrinogen are used up, then the patient will bleed out. And I've seen a couple cases of this when I worked myself in a critical care unit in ICU. A lot of times what they'll do is when the patient goes from, microemboli to bleeding, it's probably almost too late when the patient does start to bleed. They may give the patient platelets, chiroprecipitate, which actually contains fibrinogen to help with clotting, and they'll even give fresh whole blood. Initially, when they see those microemboli start forming, they may give a low dose of heparin if the patient is considered at risk, okay? And with that low dose of heparin, that will hopefully prevent those microemboli from forming. So if the physician really feels that this patient is really, really at extremely high risk to develop DIC, they'll start that heparin therapy. But as I said before, once the bleeding starts, it's really, really too late to give the heparin, okay? And it's a very, very awful way for these patients to really die, because what occurs is without any of these clotting factors and platelets, the patient just bleeds out of every orifice, and they kind of sanguinate, anal, vaginal, mouth, in the GI system. So it's internal as well as external bleeding, and it's a very horrific way for someone to die. But that's basically what it is, DIC, disseminated intravascular coagulation. It's a defect, often fatal, that causes an activation of the intrinsic clotting system, which obviously involves the blood, by the release of factor 12. Okay? So as I said before, they might also give fresh frozen plasma, but sometimes even patients who develop leukemia, as we talked about the other day, may be a person who might be at risk because of the cancer. They would be a excellent candidate for someone who would be at high risk to develop DIC. So I just kind of wanted to touch on that. You may learn a little bit more about that in 213 in your next nursing course, but I kind of wanted to bring a little awareness about that since we are talking about clotting disorders, platelet problems. I felt that DIC kind of fit in there with what we've been discussing as far as bleeds. And I think it's just important not only to just grossly understand what's happening, but also to realize, okay, what patients I'm going to care for are at risk for developing DIC. And as I said before, it's usually caused by some kind of major insult to the body. And sepsis is a really, really common reason why a patient would develop DIC. But again, it could be due to, any kind of trauma, cancer, shock. And remember, think about the woman who delivers in contaminating surroundings, or even somebody who develops abrupto placenta. Those are other reasons why they might develop DIC. Okay? All right. All right, now we're going to talk about this next chapter, care of the patients with cancer. And we've touched on some of these topics throughout the discussion of disorders with red blood cells, white blood cells, and platelets. So some of this may not be real unfamiliar to you. Okay. This first slide is just what we might see with a patient who has been diagnosed with cancer. Surgery is obviously a very common treatment. It's one of the oldest forms of cancer treatment. Sometimes prophylactically they'll remove certain organs. For instance, now they're doing some genetic testing which might tell a woman she's very predisposed to breast cancer and may prophylactically have both of her breasts or one of her breasts removed. Obviously surgery for diagnostic purposes just, definitely validates the presence of cancer. Sometimes surgery can be a cure where they remove all of the cancerous tissues. Control, removing a part of the tumor, palliative treatment, which may improve quality of life. Second look surgery, where they may re-diagnose after surgery. And then, of course, the reconstruction will, increase function, enhance appearance, or even both. Think about a woman who has to have, a bilateral, mastectomy. Maybe they'll do, a breast reconstruction on that lady. Think about somebody who may have, revision of scars, or maybe someone who's been on in the bed with bedridden contractures. Maybe they'll do surgical interventions to release some of those contractures. Okay, so that's kind of what would be the many reasons why there would be surgical treatment for patients with cancer. Okay. And this is just showing a picture of a resection of a pancreatic tumor, okay? And then we've talked a little bit about this because, cancer is one of those diagnoses that, probably has touched all of us in some way or the other. We know a family member or a friend who's been diagnosed with cancer. So we're very familiar with how cancer affects not only the patient, but the loved ones, the family unit. And it not only affects the physical, but it also affects the psychological functioning of a person. We know cancerous cells destroy normal tissue. It destroys the function of that tissue or that organ. And the death from cancer is basically caused by the metastasizing, okay? And we know cancers that are left untreated start to affect, the blood-producing function of the bone marrow, causes reduced immunity, altered GI structures and function, affects motor and sensory deficits, and also if people have a tumor in the lungs, obviously it's going to decrease respiratory function. And obviously that causes our patients to have extreme shortness of breath. The two ways that we, try to eradicate these cancerous cells is through radiation therapy, okay? And obviously the purpose is to destroy these cancer cells with definitely minimal exposure of the normal cells to the damaging actions of radiation, okay? And two ways in which we can do this is through teletherapy, which is that distant treatment in which the radiation source is external to the patient. And then we can also do brachytherapy, which is short or close therapy. The radiation source is actually within the patient. So I want to talk a little bit about these two types of methods of radiation therapy for our patients, okay? Most of the radiation that we provide our patients when they have cancer is called ionizing radiation, okay? And there's three different types of energy that is used. There's gamma, which is the most common and which also penetrates deep tissue. Then there's the alpha, which we really do not see used for cancerous tumors. And then the beta, that type of energy has to be very close to the patient in order for it to be effective, okay? So gamma is the one that we use the most often as far as the types of energy with radiation treatment. Obviously, exposure, which is the amount of radiation delivered to a tissue, the amount absorbed by the tissue, the radiation dose, where it should be less than exposure. And there's also the three factors that determine the absorbed dose: the intensity, the duration, and how close that source of radiation is to the actual cancerous cells. And really, the total dose of radiation depends on the size and location of the tumor. Because think about some of the areas in which people, get cancer. Some normal tissues are much more sensitive than others. The breast is obviously more tolerant of radiation than maybe the liver, okay? And when radiation is used as a treatment and a therapy for cancer, it causes cell damage by killing the cell or preventing the division of that cell. So there is more damage to the cell if we radiate during the cell cycle, okay? And remember, different cancer cells will respond differently to radiation. So that's kind of how it basically works, okay? And if radiation is high enough, all cells are killed immediately. But that doesn't happen with cancerous radiation because all cells within the tumor absorb the radiation dose slightly different. Some of them may die within 24 hours. Some of them are sterile. Some repair the damage the radiation puts in them. And so what they do is they usually give radiation a series. They start with a very small dose to allow that greater destruction to cancer cells while decreasing the damage to the normal cells or the normal tissues, okay? And when we talk about teletherapy, okay? And teletherapy is, distant treatment. It's external to the patient. So the patient would stand in a certain area and then they would beam from a distance that radiation. So the patient is not radioactive and they're not a hazard to others. So once it's determined the exact location of the tumor, the patient must be in that same position for all subsequent treatments. So that's what they do is the radiologist or whoever is providing this treatment will mark that area so that, and that really takes a long time in that first radiation treatment just to get that radiation beamed at the perfect spot of where that tumor is. They'll do position fixing devices and markings on the patient. And so that particular marking of where that tumor is will remain on there for the remainder of how many treatments that person receives, so that that radiation beam will go to that exact spot each time. And so that's why we do some teaching with these patients when they do have these markings put on them. It can be a tattoo, it can be an ink marking, or it can actually be a drawing, okay? So that's kind of how they do the teletherapy. Now the brachytherapy is short or close therapy. It's where the radiation source comes into direct continuous contact with the tumor tissues for a specific period of time. It provides a high dose of radiation and a limited dose in surrounding normal tissues, okay? And what they do is they use some kind of radioactive isotope, either in a solid or within body fluids. And the patient can emit radiation for a certain amount of time and really is hazardous to others. An example of that would be if they have thyroid cancer. There's a concentrated amount of radiation in the gland and it hopefully will kill that cancer cell. And when it's unsealed, it can enter, body fluids. And those unsealed, isotopes are eliminated in waste products and should not be touched by other people. So once the isotope is eliminated, patients or body waste are radioactive. But most of that is actually eliminated in about 48 hours after the isotope is given, okay? And these isotopes can either be unsealed or suspended, oral, IV routes, and it can also be instilled, within a body cavity. think about someone who has prostate cancer. This is another method of the type of radiation they would use on that patient. They can be sealed or unsealed radiation sources implanted within or very near the tumor, and it can be either temporary or permanent. And as I said before, most of these implants will emit continuous low-energy radiation to those tumor tissues, okay? Some stay in the tissues on their own, and others have special applicators, okay? And some of these are so small that the half-life of these isotopes is so short, the device is permanently left in place. And that one example, as I mentioned before, is prostate cancer. And other devices are removed and reused in other patients. So that's how it works. And even with the solid implants, the patient can still emit radiation with the implants in place, but the waste products are not radioactive or hazardous. And those traditional implants really deliver a low dose rates of radiation continuously, and patients can be hospitalized for a few days. With the high dose rates, patients come in several times a week, and a stronger radiation device is placed in only for an hour or so each time, and then the patient will go home between treatments and is radioactive only when the implant is in place. But sometimes then they'll take it out, and then the patient will come in maybe the following week for another treatment with one of those implantable devices. So that's kind of how it works, okay? Another thing to remember that radiation will kill the DNA, especially in faster growing tumors and tissues, okay? And I think you have to remember too that these implanted or ingested radiation devices can be dangerous for those you are living with, or for people that are actually taking care of or treating. So caregivers are educated about using protective shielding, limiting time around them, and increasing distance. Your book, please go over some of the safety guidelines and safety precautions when you have a family member who has one of these internal radiation devices, so you know how to not only care for the patients, how far away you should be with the patient, but also about handling secretions or waste products. Obviously, if you're pregnant, you would avoid this person completely. And sometimes family members or caretakers will have an actual little thing on their clothes that actually monitor how much exposure to radiation the person has been around. And it might also be advisable to use a lead apron and gloves to protect yourself, okay? So be sure and, go over those guidelines in your book. With those implanted isotopes, patients obviously would be in a private room, and then you would want to dispose of bodily fluids per hospital policy, along with handling bed linens and clothing per hospital policies. Also, say for instance one of these implants would become dislodged, it is advisable per hospital policy to dispose of those in a lead container because they are radioactive. So that's a little bit about radiation therapy for cancers involving teletherapy and brachytherapy. Okay. And this is just, looking at the cells. And obviously, with radiation therapy, any side effects can occur. All right. They will vary according to the site. Local skin changes and hair loss that will likely be permanent depending on the total amount of radiation that's absorbed. Altered taste sensations. Many times these cancerous cells have metabolites that are released from dead and dying cells. So people start developing an aversion to certain foods. For instance, they kind of have a funny taste in their mouth, and maybe they, don't like the taste of red meat anymore. So that may be the cause because of the radiation. Fatigue is huge. It's related to the increased energy demands. It may last weeks or even months. So people have to basically readjust their life because this is not going to go away, especially if they're having reoccurring treatments, maybe for 5-6 weeks, depending on the extent of their cancer and exactly where their cancer's at. So that's things that you got to think about. And of course, inflammatory responses that can cause tissue fibrosis and scarring. And a lot of times, say for instance, if someone's getting radiation for uterine cancer or the colon, maybe later on they might see problems in their life where they might have constipation, or even because of the scarring might actually develop obstruction, okay? Also looking at skin, worried about breakdown, dryness, things like that is something to think about in regards to the treatments. Then we have nursing care of patients undergoing radiation therapy. Teach accurate, objective facts to help patient cope. Do not remove markings. Administer good skin care. These patients obviously are going to be very, very anxious. It's fatiguing to have to go, if they're getting external, teletherapy radiation, to make their appointments. Be careful about the use of lotions or ointments unless the radiologist prescribes them, because many times with repeated radiation treatments, the skin becomes extremely sensitive, and certain lotions might have something in it that may cause further irritation or burning to the skin, because now with that radiation exposure, the skin becomes very sensitive to certain substances in some of these lotions, okay? Now you want to think about some of the areas that are very, very sensitive and most sensitive to radiation: bone marrow, the skin, mucous membranes, hair follicles, and reproductive tissues. So many times if they're getting radiation in another area, we would definitely, shield the abdomen, especially, the testes and the ovaries, to prevent any exposure to those eggs and sperm to the radiation. And remember, some of these changes that occur with radiation may be permanent, okay? Things that we see if patients have head and neck damage, from the radiation, might obviously affect the salivary glands. So because they don't produce enough saliva, mouth becomes very dry, and many times these patients are at high risk for tooth decay, okay? In the throat and the chest, if that's where the tumors are at, sometimes we see people have long-term residual effects and problems with swallowing, okay? Avoid direct exposure of the skin to the sun, and that's a really important thing, especially if people really like to be in warm places and be out at the beach. Sometimes up to a year, it's really recommended that the people stay out of the sun because it can cause some very, very serious burns. Care for xerostomia, which is dry mouth. Remember, bone exposed to radiation is more vulnerable to fractures. You want to think about that kind of stuff. So we've talked somewhat about radiation. Now we're going to talk about the other treatment. Now remember, with cancer, we might see both of these provided, or maybe just one provided and not the other, or maybe we're seeing the patient getting both chemo and radiation treatment. And that's all dependent on how quickly the diagnosis was made, where the cancer's at, Obviously, that will be the call of the oncologist to determine what's the best treatment for that specific type of cancer. Okay. We know chemo is a toxin. It treats cancers with chemical agents. It's one of the major roles in cancer therapy. Sometimes it can cure and increase survival time. Some selectivity for killing cancer cells over normal cells. And remember, those normal cells that are most affected by chemo are going to be the skin, the hair, the intestines, the spermatocytes, and the blood-forming cells that we've just talked about. Chemo will again damage DNA and interfere with cell division. Tumors most sensitive to chemo are the ones that have rapid growth. Cancer cells have the ability to metastasize, so they can actually separate from the original tumor and spread to new areas. Chemo can help kill the metastatic cells, and chemo can be used with surgery or radiation, adjuvant therapy. And remember, chemo is termed cytotoxic, not only killing cancer cells, but also kill the healthy cells. And remember, normal cells that divide rapidly are most affected. Those would be the skin, the hair, the intestinal tissues, the spermatocytes, and blood-forming cells, as I just said, okay? So that's a little background on chemotherapy, okay? These are just the different categories of chemotherapy drugs. The antimetabolites, which fool cancer cells into using the antimetabolites in cellular reactions. Anti-tumor antibodies, they actually damage the cell's DNA and interrupt DNA or RNA synthesis. The anti-mitotic agents. These really are agents that will not allow the cancer cells to complete mitosis during cell division. Alkylating agents inhibit cell division. Topoisomerase inhibitors disrupt an enzyme needed for cell DNA synthesis and cell division. And then there's also miscellaneous chemotherapeutic agents. And of course, we talked previously about combination therapy. You never want to use two drugs that have the same nadir. And again, nadir is that bone marrow activity where the cells are all at their lowest. That's basically the categories. You're not going to have to know anything specific about these. I'm just giving you that awareness that they may use 2 or 3 different types of these chemotherapy drugs. And again, we've already talked about the reasons for that, okay? The 3 different reasons of why they use different chemos from different categories, okay? Of course, treatment issues, drug dosage calculated according to the type of cancer and the patient's size. They develop a schedule, okay? Regular basis and time to maximize cancer cell kill and to obviously minimize cell damage to normal cells, okay? Remember, these chemotherapy agents are vesicants, okay? Most of them are given IV, require special education and certification to be able to administer these because these are vesicants, and vesicants are chemicals that actually damage tissue. Many times they might be administered every 3 to 4 weeks for a specified number of times. There's what we call dose-dense chemo, which is very aggressive cancer treatment, as in the breast. Just a little information about that. Extravasation is, we want to prevent. What that means is it's leaked out in the tissues. There are some medications that can be given when an extravasation occurs. Many times there's antidotes that may need to be injected into the area to hopefully save, that tissue without being damaged or causing necrosis, okay? And these are all the side effects of chemo: anemia, neutropenia, and neutropenia, and thrombocytopenia. Alopecia or hair loss, nausea and vomiting, mucositis in the entire GI tract. You know, what happens with these patients are, you know, it kills out the normal flora. So many of these patients kind of become, they kind of auto-contaminate themselves. This mucositis can just start in the mouth and kind of, you know, go throughout the whole gut, and, you know, really prone to, you know, acquiring many infections. Skin changes, anxiety, sleep disturbances, altered bowel elimination, and even so much as changes in cognitive functioning, okay? And as I said before, mucositis is when these infections develop because of overgrowth of their own patient's normal flora or loss of that normal flora, and that's why, you know, they develop these serious problems. Their immune systems are just basically, you know, shot, and that's why a lot of times they'll give those synthetic growth factors like Neulasta or Neupogen to help increase the production of white blood cells, so they're not left entirely defenseless against pathogens and bacteria, okay? That's why, as we talked about with neutropenia, we watch any type of subtle change, just so much as a half of a degree in their temperature increasing, reporting any signs of infection like a cough, changes in skin or mucous membranes, you know, assessing and auscultating lung sounds, looking in the mouth, and even just looking at peripheral venous access sites, okay? We really encourage good hygiene, mouth care, especially under the arms and in the perineal area. So, and that's when, like I said, they'll provide some of these BRMs, or biological response modifiers, which encourage the stimulation of the bone marrow to produce these cells that they are so much lacking because of the chemo that's destroyed all these cells. So obviously with the chemotherapy and the way we've pretty much wiped out all their cell counts, these patients are, you know, truly at risk for sepsis. So if they're at risk for sepsis, obviously they're at risk for DIC. Of course, induced nausea and vomiting, where we might try to provide antiemetics for these patients, the mucositis, the alopecia, you know, obviously changes in body image, which can affect these patients psychologically, changes in cognitive function, and, you know, peripheral neuropathy, very similar to the type of neuropathies our diabetics get. So, of course, at that point, we have to worry about patient safety, okay? And again, this is NADAR, which is that peak action of drug, which provides, unfortunately, the lowest point in a patient's CBC, okay? So hopefully that makes sense to you, okay? Some hormones may make hormone-sensitive tumors grow more rapidly, okay? And so some tumors actually require specific hormones to divide. Therefore, decreasing the amount of these hormones to hormone-sensitive tumors can actually slow the cancerous growth rate down. So many times what we see with these patients are they will, you know, give certain type of hormones to manipulate the amount of hormones in a person. But then, unfortunately, by doing this, we see some unfortunate side effects occur with hormonal manipulation. And what we see is androgens and anti-estrogen receptor drugs cause masculinizing effects in women, and for men and women receiving androgens, acne may develop, hypercalcemia is common, and liver dysfunction may occur with prolonged therapy. And so now you have women manifesting, appearances that men should manifest. And obviously, one of the big things we see with men is they develop gynecomastia. Women start developing hair, and vice versa. Men start developing manifestations that resemble a woman. Okay. And I think it's important to remember, too, that when they do this hormonal manipulation, because as I said in the first slide, that hormones can actually accelerate the growth of these cancerous tumors, that it will slow down the progression, but it doesn't cure the cancer, okay, by doing this hormonal manipulation. And again, good teaching to patients as well as families about infection at the hospital and in the home. And, as I said before, with these women, what's going to, again, happen is because they're giving them, testosterone and things like that to decrease the amount of estrogen and progesterone in the body, these women will have chest and facial hair, and even their menstrual periods will stop. But for both men and women, it's important to know that by giving these hormones to kind of reverse how a woman should look or how a man should look, they're both at very high risk for DVTs, okay? And maybe with this type of therapy for cancer, some of these men or women may need some counseling for the many changes that occur, okay? So that's important to do, to give these patients a lot of psychosocial and psychological support. And this is the gynecomastia that may happen with men. All right, another therapy they may do is photodynamic therapy. It's a selective destruction of cancer cells through a chemical reaction triggered by different types of laser light. And what they do is, with photodynamic therapy, they use a drug called a photosensitizer, or a photosensitizing agent, and a particular light absorbed by all cells. But this agent will stay in cancer cells longer than normal cells. So what they'll do is they'll, about 24 to 72 hours, the tumor is exposed to the light. So it will definitely, hopefully, kill the cancer cells and kind of activates the immune system, okay? But the important thing to remember is the patient may have general sensitivity to light for up to 12 weeks after the photosensitizing drug is injected. And men may also notice too, and I wanted to tell you too, with that hormonal, they're going to have a lot of changes in their private parts where they might see testicular and penile atrophy. So you need to warn men about that. I'm sorry I forgot to tell you that with hormonal manipulation. So that's photodynamic therapy, okay? And obviously when they have these treatments with this photodynamic therapy, we want to make sure patients bring proper clothing so that they're not being exposed to the sunlight. And what's good to know is that it helps to decrease the size and allows a more complete tumor removal, okay? So that's photodynamic therapy. you know, you don't have to know the specifics about this. I don't think I even asked a question about this, but I'm just trying to give you a little bit of awareness on all the many different types of treatments for our patients who do have cancer. The next one is immunotherapy, biological response modifiers, drugs that modify the patient's biological responses to tumor cells. If you think about cytokines, they're small protein hormones that are made by the white blood cells, that obviously enhance the immune system. And then we have interleukins and interferons. You're probably familiar with these terms. Interleukins are 27 known substances the body makes to help regulate inflammation and immune production. So what they do is it will hopefully charge up the immune system. And interferons are cells-produced proteins that can protect non-infected cells from viral infection and replication. Okay, so that's kind of what we're trying to do here to kind of rev up and increase the immune system, so it will see those cancer cells as a foreign substance and definitely attack it. And then gene therapy. This is very much experimental as a cancer treatment. It renders tumor cells more susceptible to damage or death by other treatments. They actually inject these genes into the tumor cells and enables the immune system to better recognize these cancer cells as foreign objects, and it actually kills them. Okay. And then, of course, your HLA, it will, we all have our own HLA. They're proteins that kind of sit on our, cells, and they'll recognize that it's a different HLA and see this as foreign, and again, attack it. All right. And then, of course, I've already talked about cytokines and IL-2. And what many times with these, with this gene therapy, they bring more of these genes on board that can actually remain active for 6 months, okay, to hopefully eradicate these cancer cells. And then, of course, targeted therapy, which is a combination of some of these therapies that I've just talked about. But, of course, with all these therapies comes the potential for these serious side effects, okay? They'll use monoclonal antibodies, small molecular inhibitors. Gleevec they might use for a type of leukemia. Rituxan they might use for lymphoma. Herceptin they might use for breast cancer. Those are some of the different types of monoclonal antibodies or small molecular inhibitors they may use for these particular and specific types of cancer. Okay. All right. I've already talked about, so that pretty much just to kind of summarize what I've talked about. Just give you a little piece of that information. Obviously, I can't go into a lot of detail with cancer. I just wanted to give you a little bit of some of the therapies, and as I said before, BRM, and we've talked about this a lot. These are those growth factors that we use, like Epicrit or Epigen or Neulasta or Neupogen, to kind of stimulate the bone marrow to make more cells. It's more of a supportive therapy, more of a rapid recovery of the bone marrow, and they might receive during their chemo, during their schedules. Sometimes the side effects we might see from these are, from these BRMs is, inflammatory reactions or fluid shifts, okay? And sometimes these patients can actually, develop rigors, neural problems, and peripheral neuropathies. I've already talked about those monoclonal antibodies, okay? And other than that, I'm not going to go, into too much detail. Those molecularly targeted therapies, those are biological agents, interferes with growth of cancer cells, okay? So that's all you need to know. Just kind of giving you a little awareness of these different types of treatments. I've already talked about DIC. I kind of could have included it, here, or as I talked about with clotting problems, okay? DIC, very common in patients who develop sepsis, okay? Syndrome of inappropriate antidiuretic hormone called SIADH. ADH is a hormone that comes from our post-pituitaries, okay? And I'm not going to say this in a lot of detail because we will talk about this much more specifically when we get to our next system of the endocrine system, because we will talk about ADH. And this is obviously an oversecretion of ADH, and many of the tumors that our patients acquire will actually secrete ADH and develop this syndrome called syndrome of inappropriate antidiuretic hormone, okay? And as I said before, ADH is secreted by the post-pituitary, and basically what ADH does, it helps control the water levels in our body. And many of these cancerous tumors actually make or secrete ADH, antidiuretic hormone. And some of the ones that do this are small cell carcinomas of the lung. Some tumors actually make and secrete ADH, and others stimulate the brain to make and secrete it. And so what we see is a person really acquiring a lot of fluid. Almost looks very similar to a patient who has heart failure. So water is reabsorbed to excess by the kidneys, and it's put into the systemic circulation. We see this very common in carcinomas of the lung. And the patient really, as far as patient safety, we're talking about patients who develop fluid overload, pulmonary edema, and heart failure. So because of the massive amount of water that's being reabsorbed into the kidneys, the patients become hyponatremic, and it's more of a dilutional hyponatremia, where you think about someone in a swimming pool, and you just sprinkle a little bit of salt or chlorine in there. You can see you've got a little bit of salt, but in a very big swimming pool. And the same goes for you've got a little bit of sodium in all this vascular volume. So that's why the patients become very hyponatremic. We can actually, and many of their problems are for the fact that they develop this hyponatremia, okay? Some of these sodiums can get as low as 110. And so it's really important to obviously watch our patients' respiratory and cardiac status. And sometimes we also see CNS changes, confusion, because of the sodium that continues to decrease because of the absorption of all this water. And patients will start to be confused, have muscle weakness, actually develop seizures, coma, and death. This is probably the only time, or one of the very few times, that we put patients on fluid restrictions, okay, to hopefully prevent more water coming on board in the vasculature and causing that sodium to continue to drop. So what we might do is there's D-cyclomycin, which works in opposition to ADH. It's an antibiotic, and some of these work in opposition to the secretion of ADH. And so this might be a medication that we might treat this problem with. But the important thing is we're going to have to restore normal fluid balance, provide supportive care, and definitely assess our patient's cardiac and respiratory status, okay? The next one is spinal cord compression. This would be where, the tumor directly enters the spinal cord or on the vertebrae. And what can happen as this cancer just continues to grow, the vertebrae may collapse from the degradation of the bone from the cancer, okay? And you can see all the problems that can occur. Really, early recognition and treatment is very important, as well as maybe palliative treatment where they might start chemo and radiation on this person. Patient starts to develop back pain. They start to feel a lot of heaviness in the arms, muscle weakness, unsteady gait, and just really, has that feeling of hot or cold. Depending on where that tumor is, if it's lower, patients might start to have urinary and bowel problems such as constipation, incontinence, and even the inability to actually start urinating. It really depends on how low the compression occurs. If the patient really becomes paralyzed, that paralysis usually becomes permanent, okay? Along with palliative treatment, high-dose corticosteroids, high-dose radiation, sometimes surgery, more to make the tumor smaller so there isn't so much compression on the spinal area, and many times external back or neck braces to reduce pressure on the spinal cord. Maybe something that may help the patient along the way, okay? And then hypercalcemia is the next one, okay? That is an increase of calcium in the bloodstream. Often we see this in patients where it comes from bone metastasis. The tumor secretes parathyroid hormone, causing the bone to release calcium. The decreased mobility, because obviously with it metastasizing to the bone, patients are in extreme pain. They don't move around as much. So because of decreased mobility and dehydration, the hypercalcemia worsens, okay? This can very slowly happen. We don't see it really like emerging, but it may not become evident until the serum calcium levels are greatly increased, okay? Sometimes just hydrating the patient better can help with the higher calcium levels. Usually we give, normal saline, glucocorticoids. Patient starts off maybe as a little fatigued, loss of appetite, nausea and vomiting, developing constipation, all the signs of excess amounts of calcium. Loss of deep tendon reflexes, paralytic ileus, dehydration, and we can also see some electrocardiogram changes, okay? We see this a lot of times with some of the lymphomas, lung and breast cancers, okay? But it can happen, with any type of some of these tumors, okay? So these are some of the management, oral hydration, and that might be enough for some patients. Normal saline, drug therapy, and obviously dialysis to remove these high levels of calcium, okay? The next one is superior vena cava syndrome, where if you think about where the superior vena cava is, and let me show you that picture right here. This is where the superior vena cava is, and you can see where the tumors are, where they are compressing that superior vena cava. And because of that tumor growing there, poor perfusion through that vessel, where we can see a formation of clots. And you can see the tumor here, and you can see how problematic that would be. The condition can obviously lead to a painful, life-threatening emergency. That makes sense. Think about it. Okay. Signs include edema of the face, Stokes sign, edema of arms and hands, dyspnea, erythema, and epistaxis. Okay. And death can actually result if the compression is not released. Okay. So what they may do to treat this type of problem is high-dose radiation therapy. They may also put a stent in the vena cava to kind of open it up where you don't have such decompression on the superior vena cava. Okay. And then the last one we're going to talk about is tumor lysis syndrome. I kind of touched upon this the other day in class. When you have such a large number of tumor cells being destroyed, the intracellular contents are